So our speaker for today is Dr. Bove. Dr. Bove is a vascular surgeon and the BMC2 vascular surgery physician champion at Corewell Health William Beaumont University Hospital, where he serves as vascular laboratory medical director. He is active in graduate medical education and has attained the level of professor of surgery at the Oakland University William Beaumont School of Medicine. He holds board certifications through the American Board of Surgery in vascular surgery, surgical critical care, and general surgery. Dr. Bove attended the University of Michigan for medical school, followed by his general surgery residency at William Beaumont Hospital, surgical critical care fellowship at University of Connecticut, Hartford Hospital, and vascular surgery fellowship at the Cleveland Clinic. So Dr. Bove, we welcome you this morning at our coordinator meeting, and we are anticipating a great presentation. Thank you. Oh, and I'm going to give you screen share.
All right.
There you are.
Hopefully you guys can hear me.
I can hear you.
Okay. There are 44 slides. I promised Rebecca I would fly through the many unnecessary slides that I have. And by the end of it, hopefully you'll understand why confusion exists. So that's why I gave it this talk, this name, Quagmire of Confusion regarding Carotid Duplex interpretation criteria, because truly it has totally evolved over the last half century. No financial disclosures, unfortunately. My only public service announcement is this: the real reason dinosaurs, although it just went down, all right, it became extinct. So let's get on with the show. This is an old-time vascular lab from the 1940s. And so, things have dramatically changed from this. And that's what an ultrasound looked like, and looking at the carotids. The original methods of carotid diagnosis actually were cerebral angiography. And what they would do is take an 18-gauge needle and insert it directly into the common carotid artery, low in the neck, and inject dye. And that was a procedure that was actually done as recently as like the 1980s and 1990s. There was another method of measuring carotid stenosis called OPG. The GEE is somebody's last name, where they would put a suction cup on a person's eye and measure differences in pressures in the eyes and determine degree of stenosis, although not specifically whether there was a stenosis or not. So there have been multiple different methods of obtaining the degree of stenosis. And this is from an old book, 1988, that basically describes the angiographic means, where if this is the carotid bifurcation, and I'm using my cursor, hopefully you guys can see that, this point labeled A is the tightest area of narrowing, and you compare it to the point labeled B, where the artery becomes sort of normal in appearance. That is the basis for measuring carotid stenosis when we do angiograms or CT angiograms or MRIs. As I said, there are multiple different ways of measuring. So duplex ultrasonography is most commonly utilized. It's done in doctors' offices. There's no radiation. It's low cost. But you'll see in the upcoming slides, there's a huge amount of variation for a few different reasons. CT angiography is utilized commonly, but it involves radiation, involves dye, and there are even discrepancies when reporting those studies. MR angiography is really expensive. It's a limited resource, and you have to lay perfectly still if you've ever had an MRI for at least a half an hour, maybe longer. So it's hard on the patients. And what's considered the gold standard is contrast angiography, which back in the olden days, they would put an 18-gauge needle in, but now what they do is snake a catheter, commonly from the wrist or the groin, and directly inject dye into the arteries. But even that has its limitations. So the most user-friendly thing is duplex ultrasonography. The documentation that is needed in a report. Imaging documentation has to be present. They've got to actually see a stenosis. But the most sensitive measurement are the velocities that are input. And you're going to go over that further in the presentations later on. But basically, what velocity measurements are measuring the speed of blood flow past a point. And it's similar to like when you put your thumb over the end of a garden hose, the water squirts out quicker. Or if you're driving along the expressway and you go from 4 lanes to two, as the cars approach the narrowing, they slow down. Once you're within that narrowing, the cars start to speed up. And once you're at the end of the blockage in the road, the cars really take off chaotically. And that's the exact same thing with blood. As blood approaches the narrowing, the velocity slows. Within it, it starts speeding up. And then at the end, that's where it becomes very turbulent. So really, it's like driving down 696 and going from 4 lanes to one or two. That's how to think of it. And this slide just demonstrates sort of with ultrasound, we can see the area from basically your collarbones up to the base of the skull. We can't see the aortic arch, which is below this dark line. And these two photographs just are images of people that you can't examine. If somebody had their neck totally where you couldn't access it at all due to a cervical collar or a traditional dressing, then you would not be able to do a carotid duplex. An important part of performing a carotid duplex, and I would ask the organizers to potentially include this in the data capture, are brachial blood pressures. You don't commonly think, oh, what's that have to do with a carotid duplex? But as in the slide before, we also see what's going on with the subclavian arteries and the vertebral arteries that go up to the back of the brain. And by obtaining a simple blood pressure on both arms, you can identify if there's a narrowing in the subclavian artery on the left or the innominate or subclavian artery on the right. So I would encourage that to have a complete carotid duplex, that you need to include bilateral systolic brachial blood pressures. And generally, when there's a difference of 20 millimeters of mercury, that's when you consider it to be a significant difference between the two. And the left subclavian stenosis is the most commonly missed finding in carotid duplex ultrasound. So it's an essential part. Basically, scanning is you put a ultrasound probe on the neck. You can look at the arteries down in the chest. It's just not perfect. But the traditional way is looking at their neck to look at the arteries. You will see a couple different things. So the reason it's called duplex is that it's not only looking at the artery. So here's the carotid bulb. You can see this is a plaque within it with calcium specks, and this is the internal carotid artery to the left. The person's head is always to the left, and the person's body is to the right. That's how we tell directionality. The reason it's called duplex is you have an image and you're measuring blood flow. That's why it's called duplex, because there are two different things. In addition, we also can add in color, and this picture to the right demonstrates changes in color, which represent turbulent or fast blood flow. So those are things that we see as well, and it complements what's called the grayscale image, which is the image to the left. You can look at the common carotid artery. This is an example of a very clean common carotid artery. You really don't see any atherosclerosis. Then you work your way up. In this image, there's a little bit of atherosclerosis, and you can see the technologists used color to show the flow lumen. You can see the external carotid artery. The external carotid artery can have atherosclerosis, and there are branches coming off of it. Oftentimes it's smaller than the internal carotid artery. But the thing that we're mostly concerned about, and this just shows a stenosis in the external carotid artery with a high velocity measured up there. So you can have a stenosis in the external carotid artery as well. But what we are most concerned with is the internal carotid artery. So this image shows a proximal and mid, that's the P and the M, internal carotid artery. You can see a plaque that's lining it, but it doesn't tell you anything really about the degree of stenosis. You've got to measure the blood flow in there. And so this image here identifies a peak systolic velocity of 65, which is normal. And then they moved along the artery, and you can see another measurement. And then they moved even further along the artery to the distal, and you can see a third measurement. So it's important to have several measurements along the artery. Typically, you choose the highest velocity. Now, this is only the peak systolic velocity. When we say peak systolic, it's the velocity at the top of the waveform. And that is a key number, which I'm sure they're going to have you record. The end diastolic velocity is at the bottom of the waveform before the next heartbeat. So those are all key numbers to record, and they should be in all duplex reports. And that is the most sensitive measure to determine the degree of stenosis. So we look at peak systolic velocity. So that's the top of the curve. End diastolic velocity, that's the end of the blood flow before the next heartbeat. And then you look at the ratio of that peak systolic velocity as it's measured in the internal carotid artery and in the common carotid artery. And those are the determinants in determining how tightly narrowed a blood vessel is. The original criteria prior to 1995 was called the University of Washington criteria. And there they had their peak systolic velocity was quite low. If you had a greater than 125 centimeters per second, it could fall into a greater than 50% stenosis. They mainly, however, were focused on end diastolic velocity to determine a very severe narrowing of greater than 80%. Then there are a few trials that helped us figure this out. The NASCET trial, North American Symptomatic Carotid Surgery Trial, European Carotid Surgery Trial, and there were asymptomatic trials as well, which helped us figure out, okay, what duplex criteria do we use? And it was the NASCET criteria that really came up with the standard of measuring using the tightest area versus the area of the internal carotid artery distal to that. And this is how we determine how to treat symptomatic versus asymptomatic patients. The NASCET trial identified that if you have somebody who has a greater than 70% stenosis and a stroke-like symptom, so TIA, stroke, or amaurosis fugax, you had a lower risk of subsequent stroke at 2 years, down to 9% versus 26% in a patient who did not undergo surgery. So that's how we determine what treatment is necessary in a symptomatic patient. In an asymptomatic patient, the numbers were not as great. They used 60% as a cutoff, but it was a 5% stroke risk over 5 years versus 11% in medical therapy. And those two studies are important because that's how we set our guidelines. So I already talked about measuring how we do that. It's the NASCET criteria. And let me just skip past this stuff. And that's what this demonstrates, NASCET. But that's for angiograms. But the reason this is important is that that's how we compare our carotid duplex to angiograms. So in 2003, a bunch of radiologists got together and they just sort of thought, okay, what velocities should we use to determine degree of stenoses? The one thing and it's called the Radiology Consensus Conference, they did set the threshold for treatment, and that's important because that is where our guidelines come for treating. So however we set our diagnostic thresholds, they've got to correlate with thresholds for treatment. So that's one area of confusion that you'll see. A few years later, Dr. Gornick, who at that time was at the Cleveland Clinic, surveyed ICAVEL laboratories. ICAVEL was the Intersocietal Commission of Accreditation of Vascular Labs. Now it's called just IAC. And they looked at 152 laboratories And when they looked at those laboratories, there were 17 different criteria being used among 117 of those labs. So a huge diversity in what people would call degree of stenosis and what thresholds for treatment were used. And using this is the Society of Radiology of Ultrasound Consensus Conference, use of what was reported in 2003 was very variable. In 2014, that Intersocietal Accreditation Commission updated things, and they recommended strongly that laboratories use the Radiology Consensus Conference. And then in 2021, Gornick updated the data again. So did a repeat study and looked at the NASET criteria versus the radiology consensus trial. And they looked at approximately 300 carotid arteries, 167 patients. And they did identify shortcomings that when you just use the radiology consensus conference, they were overcalling stenoses when compared to angio. And there were some patients that they undercalled it. So even though we're now 40 years after the original methods of testing, there still was a lot of variety. And we did the same thing in Michigan. We looked at data from 14 different laboratories across the state, and there were 5 different patterns that emerged of how people measure the degree of stenosis from the laboratories. 5 of the 14 also included criteria for carotid stent patients. And so I'd put them into groups. And in this group, there was really a lot of homogeneity. So that was good. So there was a lot of hospitals. The thresholds for treatment were the same, less than 50, 50 to 69, and greater than 70. And a lot of the numbers were similar that you'll see. This was our hospital. We had the highest peak systolic velocity of greater than 275, and there still was variability. There were some that used 230. We used an end diastolic of 110. Others used 100. And then the ratios tend to be the same, all at 4. So even though this group was grouped together, there still were differences. Group B, there were only 2 hospitals, and they were dramatically different. They used a bunch of different treatment threshold criteria. And then there were hospitals that all had different group C, D, and E, where there were different treatment thresholds than everybody else, and different velocities that were utilized. So in our state, looking at 14 hospitals, there was a huge amount of variety. And this just shows you the carotid stent patients, of which, again, there's a lot of variability from one hospital to the next. So, there's been a goal. Sorry, I keep getting an alarm. There's a goal of trying to bring things together to ensure quality. And the current IAC recommendation that again came out in 2021 is this, that that we have treatment categories of less than 50%, 50 to 69%, and greater than 70%. And they recommend these velocities and with respect to peak systolic velocity and end diastolic velocity in these ratios. And I'm going to show just one more thing, or it's a couple slides, but it's not many. The NASET criteria that we utilized has been redefined 3 times due to internal validation. You may hear that term. The IAC requires that you either use a previously adopted published criteria, and once you start that, you're supposed to internally update it. And that's how we got to ours. And so you may see that variability based on internal validation. We recently looked at our criteria again, and hopefully this will be published and it's going to be presented at VAM, but we looked at 3,000 internal carotid arteries. And we found that if you only use peak systolic velocity, there's a significant number of patients who change their treatment threshold. But if you use multiple parameters like peak systolic velocity and end diastolic velocity, or peak systolic velocity and the ratio, that there was no difference in comparing criteria. So, I would encourage that when we come to data collection, that not just one parameter is utilized, but that at least two parameters are utilized in order to make the call as degree of stenosis. So basically, we observed that there was significant variability in all the hospitals throughout Michigan, and that as a group, we should try to agree to certain principles on the treatment thresholds, which really should be what was set by NASET. So less than 50, greater than 50, greater than 70. And we should utilize for new labs starting out, they should use the IAC recommendation, and that we should definitely use multiple criteria in determining a degree of stenosis. And then we've got to figure out those patients who have been intervened upon with carotid stents. That's pretty much it. Just those are the oh, and I think we should mandate use of bilateral brachial blood pressure measurements. And document it as part of the report. That's commonly missed as well. And that is it.